We're excited that you guys are here. Thank you. This is the global issues in women's health. Women's health is very important. As we continue to evolve, women's health will be very, very important. So we thank you for being here. Our first speaker is Dr. Victoria Mao. She's going to be talking about C-sections in resource-limited settings. She's going to briefly introduce herself and then go into the presentation. Please guys, stay tuned, stay connected, stay engaged, and just, listen. This is different for many of you, but it's cool. Thank you.
Thank you. So I'm Victoria Moy. I am the program director for our Global Women's Health Fellowship at the University of Pennsylvania, so just on the other side of the city. I am going to talk a little bit about C-sections, so just a show of hands. It's a little bit personal, but who here has either had a C-section, had a loved one that had a C-section, like a spouse, a partner, a sister, a mom, a daughter, anyone? Right, everyone, right.
Yes.
So earlier today we heard about cholecystectomies, and they said that it was the most commonly performed surgery worldwide. It's actually not true. Cesarean deliveries are actually the most commonly performed abdominal surgery worldwide. In the US, we do about 1 million C-sections every single year. And I think it's often overlooked as a major surgery, both here and globally, especially since we haven't figured out a way to deliver a baby using the robot. It's still doing it. So I'm going to talk a little bit about kind of C-sections in general because it's near and dear to my heart, and the project that I'm working on right now in Tanzania. So just a little bit about me. This picture is from northern Uganda. I did a lot of global work through my training, and then I somehow convinced my husband, who's not in medicine, to pick up and move to northern Uganda with me and join the Peace Corps. And it was there that I was a physician educator. I basically practiced like an attending, teaching the interns and practicing and teaching at the medical school. And so I pulled away a lot of that information from there to kind of frame the way I practice medicine here, but frame my projects abroad as well. So I have no disclosures or conflicts of interest. And again, just looking at global C-section. So right now, the global C-section rate is about 21%. Does anyone have a guess as to what it is here in the States? It's about 30. It's about 30%. Working hard to try to decrease that. That's considered about too high.
Yes.
We anticipate that by 2030, the global C-section rate will be around 38 million per year. So that is by far the most common surgery internationally. There are two speeds of growth. So we can see, if you look at the chart here, chart A says the world is in black. More developed countries clearly have higher C-section rates. The least developed countries have lower rates. And then looking at Africa, I pulled that out. That's where my work is. But it's interesting. There are these two speeds in growth. So you can see that Northern Africa has really high rates. That's due to access, perception of the safety of C-sections. And then in Sub-Saharan Africa, where I'm doing my work, the rates are rising, but they're still quite low. Interestingly, places like LA have a 60% C-section rate. Places like Maine and Vermont are down to like 15%. So this really varies based on population as well. When we look at the Commission on Global Surgery, which everyone has been talking about from their 2015 paper, they actually called out C-sections as a bellwether procedure. And basically they use this to say, if a hospital system or a hospital center is able to perform a C-section safely, then they are considered to be a hospital that has this high value procedure and that they have a functional surgical system. So they use C-section as a way to say, this hospital system is functional. When we look at the safety, there are two things that affect C-section rates. There's safety, so just because they can do it doesn't mean that it's done well. And then there's access, so we have to also figure out how to make sure women have access to this. From a safety perspective, they thought, if we do more C-sections, moms and babies will be safer. We'll have less stillbirth rates, moms will survive. But what they found was that the more C-sections we're actually doing, the less safe it's becoming. They're finding that mortality rates can be as high as 1% around obstetrics, and that with C-sections alone, there's a 17% complication rate. Like that is a rate that is considered unacceptable for many surgeries here and abroad. And we found that as we're doing more and more C-sections, we're getting more and more cases of fistula formation, that they're finding that About a quarter of all fistulas now are actually not from obstructed labor, but actually from poor surgical technique. And we found that 85% of all C-sections that are done emergently, which, as anybody who's done trauma surgery, like who's seen an emergent C-section, that is a deeply uncontrolled situation, and that has resulted in a kind of a doubling of their mortality rate. When we look at access, so the Lancet report looked at access for OB care, just emergency OB care, and found that only about 2 to 18% of patients or women in Uganda, Kenya, South Sudan, and Rwanda actually got direct treatment for their OB complications. And they found that, they extrapolated that almost 1 billion women are without access to emergency OB care at all. And they found that maternal survival, which is pretty obvious for all of us, that maternal survival is linked to the ability to access anesthesia and OB care. And that by doing so, we can really significantly lower the mortality rate of women and babies. So in comparison, by the numbers, so this is clearly an access problem. So in the US, 5% of physicians are OBGYNs. This data is a little old, but they did a survey of African medical schools and found that there are almost 8,000 medical students graduating from medical school in Africa. There are only 250 OBGYN residency training positions, and this is supposed to serve about 1 billion people. And all these doctors don't stay in Africa, so there's a pretty significant brain drain issue. So 29% of the world's OBs, those that have been considered trained, are actually practicing in these low and middle income countries. So my time when I was abroad in northern Uganda was really focused on medical education, because I felt like that was the most sustainable way to make a little bit of a difference in where I was. But to understand that, you have to understand the way the system works there. So students will go to school, they go to undergrad and med school that's combined, it's 6 years long. They then go onto an internship. An internship is multidisciplinary, so they do rotations in OB/GYN, peds, general surgery, and internal medicine. In that internship, they are the primary providers of care. So they have not done anything clinical outside of medical school, and they are the primary surgeon for C-sections. They do this without very much supervision out in the health centers. When you finish your internship, you're considered this general practitioner or medical officer, and it's there that you are considered the most senior on the floor, on the wards. So you are teaching these interns how to do their C-sections. So imagine like you are general surgeon and your interns, the ones who normally are running your floors, are actually doing all of your surgeries with the supervision of maybe a senior resident. So this is where kind of our pain point was when we were abroad, trying to figure out how to train up these learners who are still trainees and train them up adequately enough that they can safely provide this care. So my current project is a safe C-section project. It's actually not very different than the safe cholecystectomy project that was presented earlier, just kind of shifted over to C-sections. It's a train the trainer program, and basically we're focused directly in Dar es Salaam in Tanzania. We chose this location because that's where our local partner is, and because Tanzania has a very interesting health system and have put a lot of money into their system. They are considered one of the top 10 countries with the highest mortality in Africa, but they have been trying very hard over the last decade to pump money into their infrastructure and health system. So over 4 years, between 2015 and 2019, they actually built 250 health centers and 69 district hospitals. So they created all of these buildings, but they have nobody to staff them. They don't know what to do with them. They are filling them with these interns, so people that just graduated medical school and saying, hey, a C-section is considered adequate provision of care, so you are going to go out to this site and perform C-sections. And so now we're noticing that in these community facilities, interns are performing C-sections, and the rates have gone from 2%, almost 2 decades ago, to now 11%, and are slowly rising. And in our higher level hospitals, the ones that are located in larger cities, have gone up almost up to 55%. So that is a lot of surgery. They found that the complications, because we're doing so much of it, is going up. So now C-sections are now accounting for 13% of all maternal deaths. And that it's about 3 times higher in these lower level sites that are staffed by kind of lower level surgeons. I was there last month for a couple weeks, and we looked at the workforce and performed a large survey of some of the physicians there. We looked at, we surveyed about 57 OBGYNs and other physicians, and we basically went and said, how do we fix this? What do we do? On a scale of 1 to 5, do you feel like you have a need for formal training for C-sections? Just very basic question. You can see that 69% of respondents said there was a great need. So they said 5 out of 5, we need better formal training. And this is important because historically, surgical training has always been apprenticeship. So like see one, do one, teach one, and that was it. And that's kind of still what's happening there. So interns will show up for their first day of work. They get handed a scalpel by a medical officer who maybe has 1 or 2 or 3 years of experience and says, watch me do this, you're doing the next one, basically. And so the idea is that we want to train up. We can't reasonably put OBGYNs in every single health center. There just aren't enough. And so the idea is that we're going to train up these interns and these medical officers to provide the care in a safe manner. We looked at the training, kind of different models. How do we teach people how to do surgery? It's really hard. And we looked at, there's not much out in the literature about how to actually create a successful course in training both anatomy, procedures, and how to manage the complications, especially in settings that are limited in the resources and capacity that they have. So when I was in northern Uganda, we didn't have, like a bunch of the places people have worked at here, we didn't have ventilators. We did have ether, maybe somebody mentioned ether. We have ether. If we had to, we did everything under spinal. If we needed somebody to go to sleep with ether, we then called their family member to come in and bag them while we finished the surgery. We didn't have Bovi, we didn't have blood bank. So we have to figure out a way to train people on how to do these procedures with those limited environmental supplies. And a lot of the literature out there was with these classroom-based learning, videos, laptops, simulators, but nobody looked at kind of low-resource simulators that were actually applicable in these health centers. So we kind of are framing our learning model, our conceptual framework kind of around this. So the phase of our study right now is we're in the qualitative interview process. So we did the large qualitative interview. We had a focus group where we focus grouped 15 surgeons or OBGYNs. And right now we're in the process of developing this training program. And the idea is that just by building up this workforce, we could ideally decrease the surgical complications. Our focus group, so we had interns, residents, general practitioners, and OBGYN specialists. And we asked them these 5 things. We basically said, give us your background, tell us about your experiences with C-sections, tell me about the complications that you had, where do you find your gap in skills were when you were an intern and where they are now, what are your limitations in terms of your environment and your supplies, and then how should we teach you this? What is your learning style? When we asked about background, this was probably the most informative. This is just a selection of some of the comments we got. So these focus groups, we did 3 groups, and they lasted about 2 to 3 hours each because people had so much to say about this. Very much, people would say, informal. They said they were just handed a scalpel on the first day. They learned on the job. Some people at larger cities had a week of a boot camp style training, which was more formalized. A bunch of patients said, a bunch of learners said their medical officer gave them the scalpel and said, you just cut here and the baby will come out. They basically said, don't worry about technique, just keep cutting until you get to the baby. Deliver the baby because you saved the baby, because that is what is considered to be most important, and then they say, you figure the rest out later. And so the background, it was amazing how resilient these learners were because they went through these stories time and time again about how they felt very helpless and overwhelmed because they were here, they had to take care of both mom and baby, and they had very little training to guide them through it all. They said that a big part of the complications that they experienced during their time as interns, it revolved around intra-op injuries, bladder injuries, extensions, difficult deliveries, hemorrhage. They basically, one intern said, we were told once you deliver the baby, you just put stitches in to close the uterus till it sort of stopped bleeding. If you cut into the bladder or the bowel, you also just put stitches in until it looks like it's not leaking. And that was it. There are lots and lots of stories about not understanding the anatomy, not knowing where organs were supposed to be. So if there is any adhesions, which obviously if you think about people having a 50% C-section rate, you're going to keep coming back for more C-sections. Adhesions get more and more difficult, and a lot of surgeons would say you basically just cut down until you think you're at the baby, and then you deliver it, and then you sew everything back in the layers that you thought were supposed to be there. And so this is all kind of supportive and indicative of the issues we have in terms of the training for that. Post-op, postpartum hemorrhage continues to be the most common cause of maternal morbidity mortality. A lot of this kind of ties into the surgical complications in terms of, if you're closing something until you think it's not bleeding anymore, not super effective in terms of actually managing other causes of postpartum hemorrhage. And then the environmental supplies are similar to things I described in that they didn't have most people didn't have anesthesia. There's very limited backup, which I think was the most alarming, in that a lot of people felt just alone. And so they feel as though having at least some training behind them would make them feel more capable of managing these complications. So in terms of our kind of training course and training module, we pulled out from the learning goals these themes that were really common in our focus groups and surveys, and they were really simple. It was actually surprising to hear, because I thought that I was going to be told, like, I want to know specifically how to do, how to isolate the uterine artery so I can ligate it, which most of us don't do at C-sections. These were actually really simple. They said, we want to learn the anatomy. We actually just want to learn what the anatomy, what to expect when we're doing a C-section. They want to understand why they're doing each step. Things like tissue handling, that was really common. They wanted somebody to actually teach them how to actually manipulate the tissue. Repairing bowel and bladder injuries, so rather than just sewing them closed, actually understanding how to repair those injuries, how to manage the scar tissue and adhesions, and then how to actually deliver the baby when presented with something that's not straightforward. And they wanted everything in terms of how to learn. So they needed all of it. So they are, like somebody else said earlier, they're adult learners. So going through repetition in terms of theory, understanding the indications of what they're doing, the materials, the instruments. A lot of them didn't know the name of any of the instruments. And so just learning the very basics of how to do surgery, and then they wanted some hands-on learning. So figuring out a way to find the balance between having some simulators that allow them to make them feel like it's real, but also being able to get kind of wet lab training where they can continue to do that at their peripheral sites. So just in conclusion, this is pretty quick. C-sections, like I said, are the most common surgery worldwide. That improving access has not actually improved maternal morbidity and mortality, and that actually the more C-sections we do, the more complications we're having. And so now we're all starting to realize that doing more C-sections is not the be-all and end-all, and that we actually have to focus on how to provide that with a lot of quality. And that this program that we're doing right now, our needs assessment that we just completed, really identified these knowledge gaps, and that we are in the process of formalizing our training course and implementing it and seeing how that evolves. So these are just my partners. Dr. Kukuli is my partner in Tanzania. My department has been really supportive, and a resident is a big part of my research project at Penn. And then these two are actually my two children, who they're two different children. I just make clones, clearly. But they are my two. So thank you.
So let's hold off questions. Is that okay? Yeah, and then afterwards. Or do you have a burning question that you want to ask? You will forget it? Okay, let's just stop right at this, yeah, so you don't forget.
Well, first of all, this is great. I'm actually in a very rural setting. I'm in a town of 8,000. I do not have an OB-GYN. I'm a general surgeon. My partner's 75. He's slowly fading into the background. We have 3 family medicine OBs who do all of the OB care. Any C-section that remotely gets dicey, they call me in. and I see the exact same things that you're talking about. So one, as I just wanted to emphasize, this is not just something that's happening in Africa.
Wow.
This is happening here in the United States in a lot of communities. Two, when you get into C-section, and you may disagree, it's a very straightforward, it's basically a trauma X-lab. And you just, the three things are anatomy, exposure, and then closure. Closure is exceedingly important. A lot of the complications you're talking about are related to closure. And what I've watched is with the family med OBs, bless them, taking huge bites through multiple layers of tissue, not really knowing. And then later I go in because of abdominal pain, that uterus is tacked up to the abdominal wall with whatever organs they managed to scoop up with the suturing. I think if you wanted to develop an effective protocol, you really just got to do the ABCs. Anatomy, technique, and closure, and it'll help. And that's what I've been trying to teach my family med OBs. I actually go in there on a simple C-section and assist them, and I guide them through, you know, their cuts, making sure they're respecting the layers of tissue, and then making sure they're respecting the layers of tissue in their closure. There's a general excitement when it comes to C-sections because there's a baby in there, you know, but it's respecting those planes and seeing that. And you know, I would be happy if you want to work out a protocol. I would be happy because it could benefit us here in the U.S. too. And as far as resources, trust me, I feel you on that too.
Wow.
Yeah. One thing that helps is pressure. You know, you put a fist in, put a push down, you'll get that uterus to clamp down, and then if you can't, you just wrap it in suture. You know, it's gonna, you don't need a Bobby, and you know, you just gotta, you know, that making do with what you got. As long as you know the fundamentals, it's gonna work out. So I just wanted to share some thoughts and volunteer myself to help if you wanted to help design a protocol, because I am currently in that, but much closer to home.
Yeah. And you highlight a good point. I think we talk a lot about global work, but the rural health in the U.S. is severely lacking in subspecialties. And I think it's interesting the way, for whatever reason, I feel like surgery, general surgery, and OB and GYN are so siloed. We don't interact at all. And a general surgeon can absolutely do a C-section, like absolutely. And it's funny that a family med OB, you know, they don't do a lot of surgery other than the C-section, and that is that kind of plays to the idea that a C-section.
There's a lot of bleeding they panic.
They do, and it's interesting because I feel like it's kind of an added thing to, not to say that family med OBs can't do them, but I think that people don't respect the C-section because they don't consider it surgery. Like, to dismiss it as not the most common surgery is, you know, I think indicative of that.
And ironically, they only asked me to get involved because I'm female. They just assumed, oh, well, she's a chick, she can figure it out.
Yeah. But it is funny, I feel like from a GYN perspective, you know, we call in our general surgery partners all the time. You know, if there's a bowel question or the appendix is wrapped around the ovary, I call them in, come take the appendix out for me, you know. And I think it goes vice versa. I feel like when general surgeons have anything touching the uterus, you know, sometimes they'll call us in to just be like, I don't, you know, that's a lady part, you know, so.
Which is just being rude, because there's no general surgeon who cannot help you with a C-section.
No, I agree, 100%, yeah.
Don't you think they're overdone?
Do I think they're overdone?
Yes.
Yes. I think.
Why don't you teach them not to do that instead of teaching how to do it?
That is a great question. So that's such a great question because so you probably remember there's vacuum-assisted vaginal deliveries. There's forceps assisted vaginal deliveries. My actual plan when I went to work with my partner in Tanzania was actually preventing the first C-section. So I went over there, I actually brought my forceps to say, let's teach you how to do forceps. And nurses and midwives. I was like, let's teach you how to do these operative deliveries. And there was zero interest. Nobody wanted to do them. I think because in a lot of the patients' minds as well, they thought that C-section was the standard of care, like that they deserve a C-section and not the operative vaginal delivery. Because I think historically, they have associated operative vaginal deliveries with fetal injury. And so a lot of people will trade, and I've heard this from the focus groups, they'll trade the mom's life for the baby's life. They'll say, I want a healthy baby, and even if that risk is much higher for mom.
Dr. Mui, can we hold off the quick?
They're not progressing fast enough, they'll start reporting and pushing and saying, oh, well, this kid, they need a C-section. They're not progressing in their vaginal delivery. They filed a complaint, they're like, oh, this doctor said they needed a C-section.
Guys.
Okay, guys, this is so interesting. I'm so happy we're having this conversation. Just to make sure everyone has enough time to teach and just to make you guys wait to the end, why don't we have a discussion at the end? No, it's good. We love it. We love it. We're excited. And that's why we have ICSUS, right? So that we can now work together as OBGYNs and surgeons, other surgeons too. All right. So our next speaker is Dr. Peterson. She's going to be talking about surgical management of ectopic pregnancy. You guys are so interesting. This is so cool. Thank you again, Dr. Mui.
I'm not sure I know exactly where to find my slide here.
Yeah, try there again, and then.
Thank you.
All right, very good. So my name is Analeta Peterson. I am presenting surgical management of ectopic pregnancy. And I have no financial disclosures. So an ectopic pregnancy is when you have a fertilized ovum that implants outside of the uterine cavity. So this is one of the most common gynecologic surgical emergencies that we face as OBGYNs. It's not uncommon to have more than one of these in a 24-hour period when we're on call. So ectopics occur in about 1 to 2% of pregnancies in the United States, and fortunately for us, at least 95% of these are actually found within the fallopian tube, which actually makes it a lot easier to manage in most cases. Now, between 2011 and 2013, ruptured ectopic pregnancies were found to cause nearly 2.7% of early pregnancy-related deaths. Now on this slide, it shows all the different places where this fertilized ovum can implant. So most commonly, like I mentioned, they are within the fallopian tube. They can also attach to the ovary. They can be in the cervix, which is not a viable pregnancy. And they're in the situal portion of the fallopian tube, as well as the abdominal cavity. I'm sure we have heard news stories of women who've had pregnancies attached to their liver and other fun places like that. So the diagnosis for ectopic pregnancy is pretty straightforward in most cases. We typically are looking at the beta-HCG level, and for patients who are not very symptomatic, this is something that can be followed over a 48-hour time span. And so in the past, when I was in training, we really focused on, or we were taught that these beta-HCG levels should rise approximately 53% in 48 hours. However, a study published in 2012 showed that we can use a slower rise, and we can look for a slower rise in that beta-HCG level so that we can make sure this is not an intrauterine pregnancy before jumping into treatment. Now, along with the additional labs that I wrote down, these are not necessary for diagnosis, but they are helpful, especially when there is no intrauterine pregnancy on ultrasound. So we're looking for things like anemia. We always need the blood type for patients who need to be treated with RhoGAM. And then I like to do a complete metabolic panel, and that is for patients who can be treated medically. So if you have elevated liver function tests or your platelets are abnormal, then you are not usually a candidate for methotrexate. I remember during COVID, I had a patient who had an ectopic pregnancy and also had COVID, and her liver function tests were elevated. Fortunately for her, the ectopic spontaneously resolved, and she did not need treatment. So the gold standard for diagnostic imaging is the pelvic ultrasound, and so this can be performed both transabdominally and transvaginal. An intrauterine pregnancy can be seen between 4 to 5 weeks gestation transvaginally. Now, you don't necessarily see the baby that early, but you can see a gestational sac within the uterus. So there is something that we call the beta-HCG discriminatory level. This may vary at different institutions. So this is a certain beta-HCG level where you should definitely see an intrauterine pregnancy. So for our institution, we tend to use around 1,500. So, and this is very helpful because if you have a beta-HCG level of 5,000 or 6,000 and you see no intrauterine pregnancy, it's almost safe to assume that the patient has an ectopic. Now, another thing that we see often on imaging is this free fluid in the pelvis, and sometimes that can be tricky. If there is a large amount of fluid in the pelvis and the patient has a positive pregnancy test, no pregnancy in the uterus, you can rest assured she likely has a ruptured ectopic pregnancy. But sometimes there is just a small amount of fluid, and I find myself looking at the images because sometimes the radiologist will say large or moderate amount of free fluid, and when I look at the images, I'm like, no, that's not a lot. And so those patients, depending on their symptoms and their exam findings, that they can just be watched for another couple of, for 48 hours. Another thing that we sometimes will see are these corpus luteal cysts. Our radiologists have gotten really good at distinguishing those corpus luteal cysts from ectopic pregnancies. So for my speech today, we are going to kind of focus on some of the more rare forms of ectopic. So we'll talk about the tubal ectopic, which is not very rare but common, and then as well as the interstitial and cesarean scar pregnancies. But in general, overall, surgery is recommended for an ectopic pregnancy when the beta-HCG level is greater than 15,000. In some hospitals, each hospital has their own protocol for methotrexate use, so they all have a different level, but greater than 15,000, you'll find that methotrexate is not very helpful. Anytime there's cardiac activity visualized within the fetal pole, if you have a large amount of fluid, you should definitely be performing surgery to find out what is bleeding. If a patient, of course, is hemodynamically unstable. A heterotopic pregnancy is when there is both an intrauterine pregnancy and a pregnancy outside of the uterus. And so in order to protect that normally growing pregnancy in the uterus, you may have to operate in order to remove the pregnancy that is not in the uterus. So patients who have a contraindication to methotrexate or they have already been treated with methotrexate and they are presenting again with symptoms, those patients have to be taken to the OR. And then of course anyone who has had more than one ectopic pregnancy on the same side should be taken to the OR as well. So for tubal pregnancies, laparoscopy is now the most common surgical approach, which is definitely beneficial to our patients. However, laparoscopy is discouraged for patients who are hemodynamically unstable, and that is mostly because for some of our institutions, some surgeons, sometimes the setup for laparoscopy can take a while. And so during that time where you are trying to, if you're like me, you're tucking the arms and positioning the patient in the stirrups and so on and so forth, that can delay the time to treatment. So those patients may need a mini laparotomy in order to take care of that ruptured ectopic. And then patients who have severe pelvic adhesions, sometimes it is discouraged to do laparoscopy. Now, when we compare salpingectomy versus salpingostomy, so salpingectomy is completely removing the fallopian tube, salpingostomy is making an incision and simply removing the pregnancy. A study showed in a randomized controlled trial when they compared the patients who had a salpingectomy versus salpingostomy, their pregnancy outcomes were the same in subsequent pregnancies. And the rate of repeat ectopic was the same. However, when that same study looked at different cohorts of women, when they compared women who had a history of infertility with those who did not, those patients with a history of infertility actually had lower rates of subsequent intrauterine pregnancy and ectopic pregnancy. So they went on to just suggest that when we are faced with a patient who has a history of infertility, you may want to strongly consider salpingostomy in order to improve her chances of intrauterine pregnancy in the future. So this is just a quick little graphic from Taline's Operative Gynecology where it just kind of shows you, honestly, in 2 steps, how to perform a salpingostomy. You're literally just making a linear incision over the fallopian tube and then dissecting that pregnancy tissue away from the fallopian tube and getting it out of the body. So some clinical pearls for this procedure, you do want to use instruments that will minimize thermal spread. That way you are not creating further damage to the fallopian tube. Injecting dilute vasopressin within the mesosalpinx. So this is going to help with hemostasis after you have made that incision within the fallopian tube. Some surgeons suggest actually incising the fallopian tube a little bit medial to the bulge because sometimes trophoblastic tissue is implanted there. You do have to make sure that you remove all of the pregnancy that is located right here. So it's at the junction really of the fallopian tube and the uterus. And so these pregnancies, because they are covered by a small portion of myometrium, the pregnancy can grow to a pretty large gestation before the patient is symptomatic. And so they can present late with uterine or tubal rupture. Now it occurs very rarely, only in about 2 to 4% of tubal pregnancies. A major risk factor is these tend to happen in patients who've had a salpingectomy in the past. So it happens on that same side where there's maybe a small portion of tube left, and that's where the pregnancy begins to grow. Now because of this, the proximity to, as you can see in this image, the uterine ovarian ligament, which is where the blood vessels are, if the pregnancy is growing right here and then that ruptures, it also disrupts that the vessels in that area, and these patients can have catastrophic hemorrhage. And of course that can lead to severe morbidity and mortality. Now one thing we have to do is we have to distinguish this interstitial pregnancy from what's called an angular pregnancy. And they probably look very similar on ultrasound. However, the embryo in an angular pregnancy is actually implanted medial to the uterotubal junction. It's basically in the lateral angle of the uterine cavity, close to the internal os. So angular pregnancies in most cases can develop normally without much morbidity. So to diagnose on ultrasound images an interstitial pregnancy, you are looking for a pregnancy that has an empty uterine cavity. The gestational sac should be more than 1 centimeter from the lateral aspect of the uterus and also lateral to the endometrial cavity. And then there's only a thin layer of myometrium surrounding the gestational sac. So this is a video that was published in the Journal of Minimally Invasive Surgery. We're not going to watch the whole thing, but he is performing a coniostomy on a patient who has had a interstitial pregnancy. I can't figure out how to fast forward it.
7 weeks of pain with an HCG of 18. Ultrasound scans show the entry of the uterine cavity of the gestational sac towards the right side of the uterus. This is clearly demonstrated in coronal view of 3D ultrasound scan. On entry, this has some occlusions from the previous surgery to the right interstitial ectopic pregnancy was demonstrated. The left fallopian tubus expected is absent. We proceeded to inject vasopressin 20 international units per mil around the artificial. As you can see, the tissue shows immediate blanching and injection of vasoconstrictors, and this helps reduce the blood loss associated with this procedure. Here we start to open up the interstitial ectopic pregnancy by using monofilament diatherapy and cutting through the uterine serosa. As you can see, the coronary tissue is now visible. This tells the operator that no further cutting is required, and the cavity where the ectopic pregnancy is implanted is now accessible. Here we use the suction irrigation to hydrodissect the ectopic pregnancy out from where it's implanted. We have found that this to be a very successful technique to remove the pregnancy tissue whole instead of breaking apart. This reduces the concern about residual trophoblastic disease, especially in a more conservative approach for ectopic pregnancies. Here we demonstrate the intact gestational sac dissected out from where it is implanted within the right interstitial space. It is nevertheless important to inspect for any residual trophoblastic tissue before closure begins. The specimen in this case was removed.
And so they will close that opening in 2 layers, just using a polysorb suture.
Represent.
So we'll move on to the cesarean scar pregnancy. This is a pregnancy that develops within the scar of a previous cesarean delivery or previous cesarean incision. And these have been classified into 2 different types. So there is an endogenic type, which is where it is implanted on the scar, but the pregnancy will kind of grow within the uterine cavity. And an exogenic type is planted in the scar, but will develop outside or grow outside of the uterine cavity into the abdominal cavity or towards the bladder. And so this occurs in approximately 6% of women who have 1 prior cesarean delivery and also have an ectopic pregnancy diagnosis. And as we spoke about with the last presentation, we are seeing, because of the rise in the number of C-sections, there is an increasing incidence of these types of pregnancies. So criteria for diagnosis on ultrasound, these pregnancies will show up as an empty uterine cavity. The cervical canal is also empty, so you know it's not a cervical pregnancy. The gestational sac is located anteriorly, and then there's only a thin layer of myometrium between the bladder and the gestational sac. So expectant management in these pregnancies is not recommended. They have been shown, if you allow this pregnancy to develop normally, when it's time for delivery, these patients will have massive hemorrhage. They will have a placenta accreta, and many of them require hysterectomy. The literature does recommend that you can consider expectant management for patients who are undergoing a miscarriage at the time, but you have to be aware that those patients are at risk for what's called the uterine arteriovenous malformation, and that presents as persistent vaginal bleeding that is pretty significant, and those patients often either require uterine artery embolization or hysterectomy. We don't have a consensus on the optimum treatment for these types of pregnancies. However, the Society of Maternal Fetal Medicine, they recommend either medical treatment with local injection of methotrexate with or without systemic methotrexate. However, you do have to warn your patients that it may take months for total resolution. I think the last patient we had like this, she actually kind of got sick of all the follow-up and the symptoms, and she ended up getting a hysterectomy because it was taking so long for everything to resolve. And then also there is surgical treatment. So with surgery, we can perform a laparoscopic resection of both that scar and the pregnancy. And then there's also hysteroscopic resection that some surgeons are doing. Ultrasound-guided vacuum aspiration is also an option. However, sharp curettage alone should be avoided. And a lot of patients who undergo the surgical treatment, they also need uterine artery embolization or some other way to kind of control the blood flow to the uterus at the time of surgery. One thing that these patients should know is that there is a very high risk of recurrence. 2 studies reported between a 15 and 25% recurrence rate. So adequate birth control after these pregnancies is recommended. Subsequent pregnancies, so if a woman has another pregnancy that implants normally, however, that pregnancy should be delivered by cesarean at 34 to 35 weeks with administration of steroids. So in summary, ruptured ectopic pregnancies are a major cause of maternal morbidity and mortality. We should consider salpingostomy in patients who have a history of infertility and also desire future pregnancy. We must distinguish between the interstitial and angular pregnancies, based on that video now we can see that interstitial pregnancies can be managed laparoscopically. And currently we have no consensus on the management of cesarean scar pregnancies, and consultation with specialists is vital. Thank you all for having me. Thank you for inviting me to speak.
We'll hold the questions to the end of the next presentation. Next we have Ebere Azumah, the ICS-US OBGYN chair, who's going to talk about engineering solutions, innovations, and collaboration as global catalysts for global change.
Yes, thank you. Everyone, let me find my presentation. All right, thank you, Dr. Peterson, for that excellent presentation. I'm excited for the Q&A. I have a lot of questions for her and Dr. Muye. My name is Dr. Azumah. As I've been introduced, I've been given the privilege to chair this specialty group. I'm excited. We're not going to talk so much about surgery, even though it's surgical, but I think it's interesting. I really do. So basically the title again is Engineering Solutions, Innovation, and Collaboration as Global Catalysts for Global Change. We're going to be looking at an organization called Love Your Menses. Steve Jobs says, innovation distinguishes between a leader and a follower. I'm a certified life coach. I think it's okay to be a follower. I don't think a leader is more important in a group dynamic, just letting you know. All right, so through my experience as the co-founder and president of Love Your Menses, and I'll talk about the organization as we go, I realized that there's a cycle or a framework of innovation. I'm using the organization I started in 2019 as the case study because it's really interesting. It's just, I love the organization and I talk about the organization a lot, and I'll share a story. There's a program we're running, it's called FlowTech for Girls. It's a STEM program within the organization whereby we service girls between age 11 to 16. We bring them in from different countries using technology. And I went to an event and I was telling everybody, register for FlowTech for Girls. It's such a great organization. They're like, really? I'm like, yes, it is. It's so good. It's a great program. The students love it. And someone was like, who started it? I was like, oh, it was me. It was just funny, just because I really, 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 really love the organization. But basically the innovation cycle always begins with identification, identifying the problem, and then creating a white paper. I always tell people that I work with, just document something, document, conceptualize what you're doing. And then the next step is research and development. Go identify organizations doing something similar. It could be something parallel, and just learn from them. Don't work in silos. Don't reinvent the wheel. It's already there. Learn from others. Give them credit. Then you pilot the implementation. You know, you don't need so much money, in my opinion, to like start something that can be a change agent. Then once you pilot the study, you make sure you evaluate it, evaluate what works, what does not work, and then refine it and reiterate. And then after that, you do a full-scale implementation and continue to improve on the program. So what are the key drivers of innovation using Love Your Menses as the case study? Cultivate a culture of curiosity. Just be open-minded. You know, as physicians, as surgeons, sometimes I think our Achilles heels is the fixed mindset, like we want to do things a certain way over and over again. And it's good, it's safe. They teach us that in surgery, right? Always do the same thing so that at least if there's an error, you can identify versus like, you know, going and learning new things. But when it comes to innovation, I think being curious and open to learning is important. The next thing is to embrace multidisciplinary collaboration. At my organization, Love Your Menses, it was really collaboration that allowed us to go from an organization that started in Boston to a global organization in 8 different countries with a budget of less than $200,000. Then invest in research and development. Research and development doesn't have to be confined in the walls of academia. My organization is a non-profit, but we do academic work. And we do them effectively because we don't have red tape, so anyone telling us how to do things, how not to do things. We've become a sample for other non-profits on how to do things and borrow ideas from academia. Empower, open innovation and knowledge sharing. Share the knowledge. Do not work with silos. I remember when I was in public health at TH Chan, the problem we've noticed in medicine is people always want to work in silos. But when you want to, you know, innovate, especially with limited budget, it's very, very important to work together, to collaborate, adapt, and be able to pivot. Those concepts that I formed was inspired by Dr. Paul Farmer, who here, I think all of us should, but I'm biased. Who knows Paul Farmer? Oh yes, you guys do. Good job. Most other places, like when I'm in proper, you know, medicine that non-global, they don't know about Paul Farmer. So it's really, really good. We're doing a good job, you guys. ICS, we're doing a good job. You guys know Paul Farmer. Paul Farmer, he was born in 1959. Unfortunately, he passed away in 2022. I basically met him before and worked indirectly with him. I say indirectly because I was in the public health department while he was in the global health division, but I was close to like the global health students, so their projects, I would be there, I would see him in that setting. But Paul Farmer, he's recognized, at least to me, as the pioneer for global medicine. I love how he practiced global medicine, and as we go further, I coined that he's the modern father for global medicine. He, as some of you know, is the co-founder of Partners in Health, still a robust organization, still working hard. I have friends that work for PIH, and they're doing good work. To me, he symbolizes the concept of innovation. That's a picture of me and him. You guys could see I was starstruck, like, oh my goodness, Paul Farmer, you were right here with me. So I was so excited to be around him, and he's such a darling and such an amazing, humble person, just a remarkable man. I don't know, those of you that know Paul Farmer, have you guys read the book Mountains Beyond Mountains? You guys know the Mountains Beyond Mountains is an analogy to Haiti, and it's just beautiful, the description behind Mountains Beyond Mountains. It basically narrates his life, his initial visit in 1983. He first started as an anthropologist before he became a physician. But his background as an anthropologist affected the way he practiced medicine or global medicine. All right, so we have traditional versus modern approach to global health. So traditional approach is we go to different countries because we know it all, because we have fixed mindset, we tell them what to do. And we have seen it doesn't work. We even see it in our current medical practice with the administrators coming to tell us how to practice. So we see it. We have a first-hand experience. And we're like, wait a minute. When I was doing my public health practice at T.H. Chan School of Public Health at Harvard, I interned in Deloitte. And at that time, I was doing a program, a solution for hospitals. And in my mind, I was like, wait a minute. You could have asked the doctors. I was a doctor already. I was like, you could have asked the doctors to tell you this instead of spending so much money on consultants to tell you what the doctors or the staff in the hospital already know. So again, top-down approach. I think that's just something that we have a problem with. Anyhow, it doesn't work in global health at this time, especially with social media and how it is. Like, people don't want you coming to their country and telling them how things run. They will take your money, but they will implement it their way. So the best approach is what I call the muddy approach, which is a bottom-up approach. The bottom-up approach prioritizes collaboration, community engagement. All right, so the power of collaboration, the power of diversity. Look at this room, it's beautiful because we have diversity, because everybody's voices are ahead. And when we hear everyone's voice, we get better. This is the power, in my opinion, of the United States, apart from the diverse food that we eat. So there's diverse perspective, there's amplified creativity, enhanced problem solving, and it's cost effective. I'm telling you, this principle have applied to our organization, and that's why I would say Love Your Menses is a successful organization. So Love Your Menses. So Love Your Menses is a menstrual equity program that focuses on menstrual health. Some people call it menstrual hygiene. I'm like, no, blood is hygienic, very hygienic. So I don't use that word menstrual hygiene at all. I call it menstrual health, and I'm trying to pioneer that for us to change it from being hygienic or non-hygienic to menstrual health. So Love Your Menses basically focuses on menstrual equity, and we would talk more about it. Our framework includes education. We just evolved to talking about the environment. Again, we will talk about it soon, but I believe if you have an innovation, you've now developed it, it doesn't have to be perfect to implement, just implement it, and the perfection comes through the process. We'll talk about the environment shortly. So we work on building relationship. I talked about the STEM program, Flowtech for Girls, how we build relationship with different girls from different countries. We also use technology to help because yes, the youth, they love technology. Technology doesn't have to be like those robotic instruments. Technology could be your phone. So it's not something too expensive, but something that is very, very important because we see that there's a huge gap in technology between the haves and have not. We see that even in the United States. During COVID, there's a huge gap between the inner city students in their academic knowledge from those in other areas. So Love Your Menses was co-founded in 2019 by me and my partner in response to the growing menstrual wellness needs of adolescents. Our goal is to dispel myths concerning menstruation, promote menstrual equity, build the next generation of leaders by providing an educational, uplifting, and supportive space for Black and brown girls, women, and all those who menstruate. We use menstrual cycle, menstrual health to motivate, because yes, there's nothing that motivates better than your body, and we've seen such greatness doing that. These are our kids right here, I don't know if you see it, to the left, where we brought them to a camp, and we just taught them about menstruation, and then we told them to use art to like describe how they feel about menses, and that's their production. Our location. We first started in Boston, and now we're in various parts of the United States. We've moved to Haiti, we're in Liberia, we're in Uganda, we're in Gambia, we're in Nigeria, we're in Kenya, we're in Sao Tome and Principe, and we're also in Ghana. We have the capacity to expand, but we just, I can't do it. I'm still practicing as a physician. I'm not going to give that up yet to focus on this. All right, so we talked about collaboration. Okay, 1 second. Oh, cannot display. Huh. Sorry. I don't know why my video cannot be displayed. All right, so we focus on collaboration. So in Kenya, we work with AFRICOM, and AFRICOM, we teach them what we know about menstrual health, and they go around and teach the other community members about it as well. All right, another video. So for concept, what we would say is we identified the problem, we came up with a solution, we brainstormed and came up with the ideation, we wrote our white paper, we implemented it. Again, perfection is, you won't get it, and it shouldn't stop you from implementing. And then we definitely review our impact, and we try to fix the problem and move on. What we've learned. From our organization, we've learned that money is important, but really teamwork is just as important. We learned that ideas are worth generating. We learned that the world needs your solution, and to go out and create. I've met many people as a life coach that have ideas, but they don't implement it. I've heard someone say that the graveyard is filled of buried ideas. So my goal is, you have any idea, come meet us. Just do it. People want your answer. I mean, it's pretty cool. Let's do great things together. Go to my website to learn more about the organization, but please, 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 the solution lies within you, whatever problem it is. If you have the solution, just do it. Don't worry too much about money. Don't worry too much about being understood. Just do it. All right, thank you. Again, Dr. Azumah. I'm going to have my team members come up front so that we could do a Q&A. And then we'll go from there. I have some questions for them, but I'll wait for them to sit down and before I ask the question. If you have any question, can you line up for the mic as well? Thank you again for you guys for supporting women's health and being here. We're very, very grateful. So let's take your questions.
I just had a quick question. When you were talking about the surgery for ectopic, I know there's been recent literature when doing tubal ligations that you should take the whole tube to decrease the risk of ovarian cancer. Has there been any consideration in pushing more towards salpingectomy versus salpingostomy with that in consideration?
I don't know. I mean, I guess it's definitely